Thank you everyone for joining on the Pulse virtual event focused on women's health. My name is Dr. Alba Pereira. I'm an NHSGP working at Charing Cross Hospital and a menopause specialist by the British Menopause Society. Today, we'll focus on premature ovarian insufficiency, POI. We'll be discussing what is POI, what causes POI, what are the symptoms and how do you diagnose POI, what are the short and long-term implications of POI, and the management of premature ovarian insufficiency. So what is menopause? Menopause is the permanent cessation of the menstruation for at least 12 consecutive months after the last menstrual period. If this happens above the age of 45, it's considered normal. If it happens between the age of 40 to 45, it's considered early menopause. And if it happens below the age of 40, it's considered POI, premature ovarian insufficiency. The average age of menopause in the UK is 51. This is a data from white Caucasian women, because if you look other ethnicities such as South Asia 46, that is 5 years down the line from the white Caucasian. Black Caribbean 47, 48. So we need to bear in mind different ethnicity during menopausal consultation. 10%, about 10% of women will have early menopause. It's about 1% of the population, 1 in 100, will develop POI. But bear in mind that this percentage change according with ethnicity. Some ethnicities, for instance, South Asia, will have a higher percentage of POI, 2 to 3%. Don't know for sure why certain ethnicities has this increase in the rate of POI. Is it genetical? Is it the environment? Is it that there's more pollution? Is it the nutrition that they have on that country? Or is it the medication, different medications that are given there? We don't know for sure. Also, we need to remember that POI can happen below 30th, 1 in 1,000, 0.1% of female population. And it can also happen below 20, 1 in 10,000, 0.01%. And so we need to be cautious with ladies that comes to see us due to a lack of periods, because POI can happen in any age. It, of course, that could be polycystic ovarian syndromes, could be another diagnosis, but we need to think about POI because the short and the long-term consequence that we will be discussing soon. 25% of ladies with POI that was not caused by surgical POI, not caused by a removal of the ovaries, they can have intermittent ovarian function. So they can eventually, in the future, end up having period, hormonal changes, and fertility and conception. 5 to 10% of ladies with POI can conceive naturally. So we need to think about contraception for that ladies. So, but what causes POI? Why the ovarian functions of some ladies stop so early in life compared with other ladies? And to answer that question, we need to go back to the physiology of a woman body. A baby girl, a female, she is born with 1 million ovarian follicles in each ovary. That number halves to 500,000 by puberty. By the age of 40, this number is only about 8,000. Hence, it's harder to get pregnant. There is a fertility issue. And by the time of the menopause, there are only 750 to maximum 1,000 ovarian follicles. And there is a decrease in number and in the quality of these follicles. Why these ovarian follicles destructions happen much early in life for some ladies is not known in 80% of the cases. There are some theories. For instance, it might be a genetic cause, it might have a gene that was not identified yet, and for that more research is needed, or that baby girl, girl, female, was born with a small pool of eggs instead of 1,000,000 ovarian follicles in each ovary. She was born with much lower number, and that number was decreasing toward life, and the pool ran out much early in life. Or she was born with the right amount of ovarian follicles, but there was a fast destruction of that ovary, of the ovarian follicles. Instead of half by puberty, she was having much less. Or something that we called epigenetic aging, which means that ovarian follicles pool starts to be destroyed much early in life, intrauterus, even before the ovary being matured, even before the 5th or 6th months of gestation. On the other hand, 20% of the case of premature ovarian insufficiency are known, and the main causes are iatrogenic, surgical menopause for removal of the ovaries due to cancer, or risk reduction surgery caused by patients that was recently diagnosed with BRCA1 gene, or post-chemo, post-radiotherapy treatment for cancers can destroy the ovaries, genetic cause, autoimmune, infection, metabolic cause, and others. 30% of unknown POI has a positive family history. Several genes has been identified, mainly X chromosome and autosomal genetic variation. That is one of the reasons why it's important to refer that lady for genetic tests and possible identification of genetic condition. Mainly, 2 genetic tests is going to be offered. One is karyotyping, mainly for Turner syndrome. And if that girl will be diagnosed with Turner syndrome, she needs to be under a multidisciplinary team for her heart, for mental health, and for several other aspects of her life. And the second test is for Fragile X screening. If a defect is identified on the X, that patient needs to have counseling. Her family might need to be screening. She might need to be discussing about egg freezing for the future. And a diagnosis of POI should be discussed in details with the short and the long consequence of the diagnosis. In addition to the genetic cause, autoimmune condition has been associated in 30% of the cases with ladies who developed spontaneous POI. That conditions include hypothyroidism, celiac disease, alopecia, rheumatoid arthritis, myasthenia gravis, and many other conditions. So it's important to test for celiac screen, thyroid antibody, ovarian antibody, and adrenal antibody. Another well-known cause, iatrogenic, it's medically caused. For instance, surgical menopause, where we need to remove the ovaries due to cancer, ovarian cancer, or risk reduction surgery, where we advise the ovary to be removed when we diagnose a BRCA1 gene. Similarly to what's happened with the mastectomy, risk reduction mastectomy, when the breasts are advised to be removed due to the high risk of breast cancer. Remember that for surgical menopause, the symptoms will be more severe, the induced menopause, the iatrogen, the medical induced menopause, the symptoms is going to be stronger because we are removing the ovary, because there is no time for the body to adapt with the gradual decrease in the level of the estrogen. Another iatrogenic, chemotherapy and radiotherapy, treatments for cancer. They can shut down the ovary. They can make the ovary stop the ovarian function. It depends on the type of the chemo or radiotherapy that the patient is having, and also depends on the age of the patient. What are the symptoms of premature ovarian insufficiency? We should suspect POI on any ladies that stop to having the periods for more than 4 months. Of course, that could be other diagnoses such as PCOS, polycystic ovarian insufficiency, could be a hypothalamic suppression, could be stress related, could be diet, could be anorexia, could be excess exercise, could be many other diagnoses. But we need to diagnose and we need to request FSH, follicular stimulant hormone tests, to rule out POI, because due to the risk, the long-term risk consequence. And what are we looking at the FSH blood test? We would like to see at least 2 readings showing that an increase in the FSH, an increase in the follicular stimulate hormone. And these 2 readings should be above 25 in 2 readings 4 to 6 weeks apart. We need to make sure that we are making the right diagnosis due to the long-term consequence and short-term consequences as well, because if she's diagnosed with POI, she's going to have the decrease in the estrogen level. So she's going to have menopausal symptoms such as vasomotor symptoms, hot flashes, night sweats, sleep disturbance. She's going to have mental health symptoms, forgetfulness, mood swings, anxiety, perhaps genitourinary syndrome of the menopause, vaginal dryness, painful during sexual intercourse, bleeding during sexual intercourse because the vaginal mucosa become thinner, and other symptoms such as headache, muscle pain, joint pain, tinnitus, and many other symptoms that we still not know that is caused by the decrease in the level of the estrogen. Remember, 80% of the ladies with POI is going to have symptoms, and 25% of that ladies is going to have severe symptoms, which affect significantly the quality of life. And what are the risks of premature ovarian insufficiency? We divide in short and long-term risks. Short-term risks are mainly the symptoms, which can affect significantly the quality of life, and psychologically, it's not an easy diagnosis to accept due to the long-term consequence, due to a perceive in the loss of a female body, of a female hormones, of a loss of her fertility, and many other implications. So she needs to be seen, and she needs to be under a psychological team. She needs to have a psychological support. And long-term risks such as bone health. That lady should have HRT until the normal age of the menopause, which is 51, mainly to protect the heart and the bone. There is an increase in the risk of osteoporosis later in life. That lady should be advised on lifestyle modification, on increase the intake of calcium, on taking vitamin D daily, on doing weight-bearing exercise, and on having the hormone replacement therapy. Cardiovascular health. It's very well known that estrogen is cardioprotective. The decrease in the level of the estrogen can increase the bad cholesterol and increase insulin resistance. Estrogen, there is an anti-inflammatory effect on the cardiovascular system, especially so that lady needs to be counseled, especially if she has high BMI, high blood pressure, if she smokes. And once again, the HRT should be offered until the natural age of the menopause for cardio protection. Fertility. So we need to assess, does this lady want fertility or she does not want pregnancy? If she does not want to have a pregnancy, we still need to offer contraception because there is a small risk, 5 to 10%, of she gets natural pregnancy. And if she would like to have fertility, if she would like to have a family, then she needs to be counseled, because once there is a decrease in this pool of eggs, one decrease on these ovarian follicles, it's very difficult for her to conceive naturally, and it's very difficult to go for egg freezing. So she probably needs to go for egg donation, she needs to go for IVS, and she needs to be under the fertility clinic, under the fertility team. And what are the treatments for premature ovarian insufficiency? First, lifestyle modification. She needs to have a diet that can support her new metabolism, that can protect her bone, that can protect her heart, high in calcium, high in vitamins, high in minerals. She needs to have strength exercise, physical activity, decrease in caffeine, decrease in alcohol, and other lifestyle modifications. Second, psychological management. CBT and hypnotherapy has been proved to be helpful for this stage of life for premature ovarian insufficiency. Herbal therapies such as black cohosh, red clover, we still need to have more data. We still need to have more research to advise it for patients, especially the ones with premature ovarian insufficiency. Non-hormonal medications such as SSRI, SNRI, gabapentin, pregabalin, clonidine, fezolinetant, and others can be offered to decrease the menopausal symptoms, to decrease the hot flashes and vasomotor symptoms. However, they do not increase and protect the bone mineral density. I believe there was a session in Menopause today that non-hormonal management was discussed, and it all valid for the same for POI, for premature ovarian insufficiency. HRT, hormone replacement therapy, is the most effective for both short and long-term consequence, implications of POI, of premature ovarian insufficiency. The replacement can be done with the pill, with the combined hormone contraception. However, it's preferable to be done with HRT because it's a much natural hormone. The estrogen is a body identical estrogen compared with the synthetic estrogen on the pills. HRT, she needs to have the estrogen, which is the essential hormone, is the one that is going to protect the bone, protect the heart, improve the symptoms, improve the short and the long-term consequence of the POI, is the essential one. Progesterone is the necessary one, is to protect the womb against the effect of the estrogen, to make the lining of the womb thinner. And we can add, in some case, the testosterone. We can also add the topical HRT, the topical estrogen, the vaginal estrogen, if the patient had a genitourinary syndrome of the menopause, vaginal dryness, recurrent urinary infection, or painful during sexual intercourse, and other symptoms related to the genitourinary syndrome of the. Generally speaking, there are three main risks of HRT: blood clot, endometrial cancer, and breast cancer. However, the premature ovarian insufficiency population is a different population. For instance, blood clot, there is a slight increase in blood clot risks for ladies taking HRT above the age of 60. This doesn't apply to POI. Endometrial cancer, there is a slight increase in endometrial cancer if progesterone is not given on the right amount. And breast cancer, there is a slightly increase in the breast cancer risk for combined hormonal replacement therapy, but that risk does not apply to POI ladies up to the age of 50, because we are just replacing. Because what we are willing with that replacement is for the body to get to a physiological level of estradiol, which she would have this physiological level anyway if the ovaries would not stop the production so early in life. How do you replace it? Is similarly to menopause, but we usually tend to give higher dose. For instance, can be oral therapy, 1 milligram of estradiol, or even 2 milligrams, because the symptoms are more severe than a natural menopause. The symptoms are a bit harder, more difficult to control. So you can do oral, or if she has a high risk of blood clots, we can do the transdermal, but in a higher dose, such as 100 microgram PAT with the proper progesterone, or 4 pumps of estrogen with the proper progesterone. Some ladies need higher dose than that. Remember, the symptoms are more severe than the natural menopause and slightly harder to control. How long is she going to be taking HRT? At least until the natural age of menopause, 50 to 51. Afterwards, we can reassess the symptoms and give accordingly as long as the benefits outweigh the risks. There is no limit of age to start or to continue HRT, especially for that group of patients, for POI, premature ovarian insufficiency ladies. 5 take-home messages for POI. First, don't dismiss symptoms. Early diagnosis and quick referral is the key to prevent the short and the long-term consequence. Second, surgical menopause. The symptoms are more severe and sudden. That lady should be counseled before the surgery happens. She should be aware what to expect after the surgery. Third, HRT should be given until the natural age of menopause, 50 to 51. Fourth, there is a severe fertility consequence. We need to talk. Fifth, we need to know more. More research needed, especially for the premature ovarian insufficiency on non-Caucasian ladies. I hope you enjoyed the talk. Thank you so much for your attention and hope to see you all soon.